Just wanted to talk to you a little bit briefly on the opioid crisis. This is something that I've become interested in recently over the last couple of years. So we're going to go over the recent opioid crisis data in the U.S. and in Canada, talk about factors that contributed to this, look at the ALTO project, Alternatives to Opioids, talk about ending the epidemic. The prescription drug monitoring program is something we all should be aware of, and then look at some future directions. So the AUA is interested in this. They had a quality improvement meeting at the end of last year, specifically directed to the opioid crisis, and all the major medical societies are getting involved in this. As urologists, we prescribe a lot of opioids. We treat kidney stones, we do major surgery, and so certainly we've been a contributor to this epidemic. So the AUA's objectives in their quality improvement meeting at the end of last year was to define the epidemic, describe steps to stem the epidemic, look for alternatives to opioids, and identify opportunities that we can improve on. We don't have any trainees here, but the trainees, urology trainees and APPs are big contributors to the epidemic as well. And this was an article recently in the AUA News about the resident and fellow contribution to this. If you look at what APPs and residents are doing at, say, teaching hospitals, they're writing for the majority of opioids on discharge. If you go home on an opioid, you're more likely to become addicted. If you don't go home on an opioid, or if you go home with a 7-day or less prescription, you're less likely to become addicted. So just making little changes in your EMR on your default discharge summaries can make a difference. So in this one quick study that residents did, they reduced the opioid usage by as much as 15% just by changing one little click in their EMR. So you might say, what is Brian Flynn doing talking about opioids, the reconstructive urologist? And I got sort of dragged into this. As the Rocky Mountain Urologic Society president, I was invited to go to the Colorado Medical Society meetings, and they've reached out to all the subspecialty society meetings in Colorado and trying to help stem the epidemic. I met a couple interesting speakers. I invited them to the Rocky Mountain meeting, our sectional meeting, and then last week I attended the Colorado Opioid Safety Summit. There's 500 physicians there from Colorado attending this meeting, and that was the day we got a big snowstorm. And it was amazing to see the attendance there. The Colorado Medical Society, the Colorado Hospital Association, and the Department of Health and Human Services. This was a big initiative from Governor Hickenlooper, and the Colorado Consortium is a blend of physicians, nurses, pharmacists, and lay people. So the goals of the summit were very similar to the goals of the AUA, to try to identify the crisis and then define alternatives. So how many people have heard of the word ALTO before this lecture? Okay, so we got it too. At the end, if you remember one thing, remember the word ALTO. So when your pharmacist says, or your anesthesiologist says, can we talk about some ALTOs for this patient, alternatives to opioids? So let's look at the epidemic. 63,000 people died from opioids in 2016. 75% of them were due to 63,000 mortalities from overdoses. I'm sorry. 2/3 of those were from prescription drugs. 912 people died in Colorado. I know there's a lot of people here from Colorado, and so some of this is Colorado-specific data. So good news is, between 15 and 16, the number of deaths from opioids actually went down from prescription opioids, but the number of deaths from heroin is going up. So as we sort of ramp down on our opioid prescribing, all those addicts that may have been created are now going over to heroin, because heroin is getting cheaper and cheaper, and heroin's not just a big city problem, it's being used in the rural communities. Fentanyl deaths are going up. There's illegal fentanyl coming in from China and other places, and people buy it on the street, and it's a real problem. Methadone deaths, we thought methadone was the answer. Methadone clinics all over the place. Methadone clinics are going to go away. They're going to be replaced by ketamine clinics. You'll see this in the next 10 years. This is a true epidemic. It knows no boundaries based on age, gender, race, income. So this meets all the definitions of an epidemic. This is a picture of Colorado, and surprisingly, you'll see in the southern counties, in the darkest red, is where the greatest amount of mortality per population occurred. So you think it's a big city problem, but it actually happens in rural communities, and it's an issue that's really rampant throughout our state. How does opioid deaths maybe compare to some of the other causes of death? Well, you can see opioid death is the only thing that's really rising, right? That's that thick blue line. It's surpassed motor vehicle deaths and surpassed firearm deaths. So despite what you see in the media, firearm deaths are actually going down. They're not going up. Certainly we have room for improvement on firearm deaths, but opioid deaths kill more people than guns or automobiles. What about the cost? Okay, opioid deaths and prescription drugs cost society a lot of money, $78.5 billion to the U.S. economy. Where is most of that money? That's that big red circle. $62 billion loss of productivity, right? So people take their opioids and they sit home on their couch and they're not very productive. And it's a huge economic loss to society. So how did we get here? Okay, for those of us that trained in the 90s, we remember being preached that we were undertreating pain, okay? And the concept of analgesia was morally reprehensible, okay? I would get a call from a nurse from the recovery room saying, we can't discharge your patient. Why? This patient has pain. What's the pain score? 2 out of 10. Okay. And what have you given so far? Oh, I just gave 2 oxycodone. What was it before then? Oh, it was an 8. I'm thinking that's pretty good. But there was such a push for pain management, and it actually became a quality measure. So when patients are filling out those surveys, what's the first question you get asked? Was your pain adequately managed? And this is a little bit of the Facebook of medicine, right? So we're all driven by surveys, right? And everyone's checking their surveys and seeing how many likes they're getting, and we all want to be popular physicians. Well, you're not real popular when you say you're not getting opioids and I'm not going to extend your disability, right? Those are not things that people want to hear. Then our grades tank. Then our boss comes in and says, why are you an outlier compared to your partners here? So opioid usage went up 400% during the 90s, in large part because of this. Some of the best legislation I see going on right now is trying to unbundle that quality measure of pain now as being a metric, because it was one of the biggest contributors to this epidemic. Certainly the pharmaceutical industry had a lot to do with this. From 1999 to 2010, the amount of opioids that were prescribed went up tremendously. 3.9-fold increase in the amount of opioids sold. Not surprisingly, you can see the orange and gold line went up parallel. More opioids being prescribed, more deaths, more people needing admissions for detox. And so the less opioids we use, the less deaths we're going to have, and the less people that are going to become addicted. So there's a lot of argument on what's the gateway drug, right? Some people say alcohol is the gateway drug. Others say it's marijuana. How often do you hear, we're going through the same thing right now in Colorado, marijuana is not addicting, marijuana doesn't lead to escalation. Well, it does. You're 3 times more likely to take opioids if you smoke marijuana. You're twice as likely to take opioids if you use alcohol. Now that certainly doesn't compare to cocaine or to other drugs, but if you use cocaine, 15 times more likely to end up on heroin. If you take opioids, you're 40 times more likely to end up on heroin. So I don't think anybody who's sitting at home in the suburbs, who's 40-something years old, who's taking opioids, thinks that they would ever become a heroin addict. But if they do take opioids, they're going to be 40 times more likely to become a heroin addict. So who's at risk? It's people ages 16 to 45, people that are already drinking alcohol, people that maybe occasionally use illicit drugs like marijuana, people that are using other prescription drugs, become interested in using opioids, and then people with mental health disorders. They're the most vulnerable patients. So if you have someone come in with this profile and they're depressed, maybe they have some attention deficit, bipolar, especially if there's a history of sexual abuse, and that's harder to elicit in a brief history, this is the patient that potentially becomes addicted. What about women? Women are 2 times more likely than men to use opioids, And women are more likely to die from the use of opioids than men. Okay, so there's higher deaths rate in women. Women are more likely to be prescribed opioids after surgery and become long-term persistent users. So I just bring up these two slides for you to think about opioids when you're prescribing and who might be at risk. So let's talk about the gateway. We mentioned about gateway drugs, and what about prescription drugs? So these are some common surgeries, and I highlighted two just to highlight the TURP operation as urologists. So 5% of people that have a TURP operation, at least in this data, become long-term opioid prescription users. How many people prescribe opioids for TURPs? Okay, 1, 2. I used to. It was just a knee-jerk, right? Any operation I did, patient got an opioid, whether it was a ureteroscopy, a TURP, or a urethroplasty. Really think carefully about this. And if the patient really wants an opioid, sometimes it's a real brief conversation saying, we could do this, but realize if you go home on opioids, you may eventually become dependent on them. It's the exact opposite of what we were taught in the 90s, right? You can take opioids, and as long as you have legitimate pain, you're never going to become addicted to that. Well, we know that's not true. Colectomy, 10%. Hysterectomy, 6%. So these are very common operations that we're all familiar with. And if you decide to go past that first prescription, if you go past 7 days, patients are going to be more likely to become addicted. How many opioids do patients really need? 91% of our patients take fewer than 15 tablets, okay? I typically would write for 50 tablets. Why? I don't want to get called. I don't want my residents to get called. Many of my patients live hundreds of miles away. If we're in a rural state in Colorado, they'd have to drive back to the medical center, or I'd have to mail them a prescription. So I tended to write for more than what I needed to. Now we're going to have some changes in our ability to ERX. So maybe you can prescribe 2 or 3 days, and if they do need a refill, you can send it electronically. What happens to these opioids left in the medicine cabinet? Well, let's take a look. 55% of people get opioids from a friend. Well, these are leftover opioids. Remember, 91% of people are only taking a few days of opioids. The rest of them sit in that cabinet, and then they either get used by someone else, right? They get used for another indication. So 70% of people obtain opioids from friends or relatives, right? So think about that. Do you want to turn one of your friends or one of your relatives into an opioid addict? Be careful about lending out your opioids from that knee operation that you got a prescription for and you never used them. What about the effectiveness of oral analgesics? Well, this slide is difficult to interpret, but ibuprofen at 800 milligrams is about as effective as 10 milligrams of oxycodone. Okay, and that's been proven in a number of studies. It's hard to sell. Patients generally, when you tell them you can take ibuprofen for your pain, they'll fill out the survey and say, my doctor sent me home with no pain medication. That's the response you're generally going to get. Or they didn't give me anything. Well, no, actually we did. We gave you ibuprofen. Yeah, well, it wasn't a prescription. So what do? Let's write a prescription for 800 milligrams of ibuprofen, right? Seems silly, but here's your prescription. Here's how you take it. Let's give them some instructions on how to do that. So this is just some of my own observations. You know, we went from undertreating pain to now the 5th vital, which is the pain score, to overtreating pain, now to an epidemic. How many people use the pain score? What's your pain, 0 to 10? Yeah, we all kind of use it. Fortunately, it's going to go away because that has sort of led to some of the epidemic, okay? I could ask someone in this room, what's your pain score? And someone might tell me it's 8 out of 10. And we've all been there with the patient who's just sitting there calmly, you know, staring at their phone. I got 8 out of 10 pain. And there's not really good objective ways to evaluate pain. So maybe a better question would be, is your pain being treated adequately? Or you know, something more open-ended rather than just a number, like a vital sign. We start chasing our tail, and then people always want to fix that number. We want to lower the blood pressure. We want to lower the hemoglobin A1C. We want to lower the pain scale. So getting to the epidemic, to quote Ben Franklin, an ounce of prevention is worth a pound of cure, right? So prevention is going to be the key. And I'm just going to speed up here. And talk about the ALTO project, right? ALTO was designed by 10 EDs across Colorado to decrease the number of opioids being used. And amazingly, they were able to do that in a 1-year time frame. So what alternatives do we have? Ketamine, lidocaine, trigger point injections, nitric oxide, NSAIDs, and dicyclomine. So these are all potential alternatives. Most of us are not familiar with most of these, but emergency room physicians are. Emergency room physicians administer ketamine. They certainly do blocks, and they do some creative stuff in the ED. Many of them are familiar with lidocaine, and so these are some things that are being used in EDs in Colorado. And in 1 year of this project, they picked 10 emergency rooms, 10 different counties, both rural and urban counties, and they were able to, every single ED was able to meet their goal. Everybody dropped their opioid usage by more than 15%. ED number 1, 46% decrease in the opioids being prescribed in that ED. What are they using in an alternative? Well, you can see intravenous lidocaine went up 451%. Has anybody prescribed this for one of their patients? Yeah, I've never done it. I have partners that have for cystectomy patients, and it's something that people are looking at. How many people have had one of their patients be prescribed ketamine? Yeah, so you can see we're gradually moving towards some of these alternatives. What about kidney stones? Well, part of the ALTO project in the ED was to get that patient home in a stone crisis without an opioid, and they were able to do it. They took patients from 69% of those patients were getting opioids, now down to 47%. So this is a protocol, and this is why urologists need to be involved. I had nothing to do with this protocol, and this is the protocol that is used in Colorado in the EDs for kidney stone patients. So finally, they're getting some buy-in from us and others. You get your ketorolac, you get your Tylenol, that doesn't work. Second line is IV lidocaine, and I think emergency room physicians may be comfortable with this, as urologists we're probably not. And I'm just going to finish up here and talk about chronic pain. And certainly anytime I head back east and people say, where are you from? Oh, I'm from Colorado. This is the first thing they ask me. Well, how's the marijuana going? You know, and you hear Jimmy Fallon and other people making fun and cracking great jokes about marijuana. But marijuana is being used for chronic pain. I don't see people necessarily using it for acute pain. We all have friends who are probably, using chronic marijuana. It's becoming more socially acceptable. It's now being used in different beverages, and it's something that we probably need to be more open to. Just finishing up on the legislative changes, there's a few that have already happened, but generally the legislation changes are going to liberalize the ERX prescribing, limit the number of days you can prescribe, and limit the number of morphine equivalents that you can prescribe. And the goal is really going to be able to reduce the number of opioids and stem the epidemic. And I'll just do one more slide. I got this email and I actually started reading these. The prescription drug monitoring program, right? So this is a little bit of Big Brother, but people are watching what you're doing and how many opioids you're prescribing. That's me in the top box at the end of 17 versus 18, and I went from prescribing 395 prescriptions for oxycodone down to 298 only a year later, and I went from 275 on hydrocodone down to 100. So that's just a change in my own prescribing habits. And then the orange and the yellow box are people around me. And so they're comparing me to my partners, to other people in Colorado. So people are kind of watching what we do, and it's something that you want to pay attention to. Has anybody else gotten these reports? Does anybody read them? Yeah. Start looking at it, okay? And it's just like anything else. You don't want to be the worst one. If you could at least kind of be with everyone else, you're going to be doing okay. Thank you.